All right, good evening, folks. Today I would like to talk about gallstones. Gallstones are more common in women than in men and increase in incidence in both sexes and all races with age. In the United States, the prevalence of gallstones is 8.6% in women and 5.5% in men. The highest rates are in persons over age 60, and rates are higher in Mexican American persons than in white and black persons who are not of Hispanic descent. Although cholesterol gallstones are less common in black persons, cholelithiasis, attributable to hemolysis, occurs in over a third of individuals with sickle cell disease. Persons who are native to either the northern or southern hemisphere have a high rate of cholesterol cholelithiasis, probably because of a predisposition resulting from thrifty LITH genes that promote efficient calorie utilization and fat storage. As many as 75% of Prima and other American Indian women over 25 years of age have cholelithiasis. Other genetic mutations that predispose persons to gallstones have been identified. Obesity is a risk factor for gallstones, especially in women. Rapid weight loss, as occurs after bariatric surgery, also increases the risk of symptomatic gallstone formation. Diabetes mellitus, glucose intolerance, and insulin resistance are risk factors for gallstones. And a high intake of carbohydrates and high dietary glycemic load increase the risk of cholecystectomy in women. Now, hypertriglyceridemia, that means like high triglycerides in your blood, may promote gallstone formation by impairing gallbladder motility. The prevalence of gallbladder disease is increased in men, but not women with cirrhosis and hepatitis C viral infection. Moreover, cholecystectomy has been reported to be associated with an increased risk of non alcoholic fatty liver disease and cirrhosis, possibly because gallstones and liver disease share risk factors. Gallstone disease is associated with increased overall cardiovascular and cancer mortality. The incidence of gallstones is high in individuals with Crohn's disease. Approximately one third of those with inflammatory involvement of the terminal ileum have gallstones due to disruption of bile salt resorption that results in increased solubility of the bile. Drugs such as clofibrate, octreotide, and ceftriaxone can cause gallstones. Prolonged fasting over 5 to 10 days can lead to formation of biliary sludge, microlithiasis, which usually resolves with refeeding but can lead to gallstones or biliary symptoms. Pregnancy, particularly in obese women and those with insulin resistance, is associated with an increased risk of gallstones and of symptomatic gallbladder disease. Hormone replacement therapy appears to increase the risk of gallbladder disease and the need for cholecystectomy. So, when you think about this risk, you need to think about all those things. The risk is lower with transdermal than oral therapy. Gallstones detected by population screening have been reported to be associated with an increased risk of right sided colon cancers. So, the risk of cancer also goes high. A low carbohydrate diet and a Mediterranean diet, as well as physical activity and cardiorespiratory fitness, may help prevent gallstones. Consumption of caffeinated coffee appears to protect against gallstones in women, and a high intake of magnesium and of polyunsaturated and monounsaturated fats reduces the risk of gallstones in men. A diet high in fiber and rich in fruits and vegetables and statin use reduce the risk of cholecystectomy, particularly in women. Even painkillers like aspirin can protect against gallstones. The role of intestinal microbiota in the pathogenesis of gallstone disease is now under research. Now, gallstones are classified according to their predominant chemical composition as cholesterol or calcium bilirubinate stones. The latter comprise less than 20% of the gallstones found in patients in the United States or Europe, but 30 to 40% of gallstones found in patients in Japan. About 15% to 20% of gallstones are calcified sufficiently to be seen on plain abdominal films. Most gallstones comprise mixed components, including cholesterol, bile salts, and biliary pigments. Pure cholesterol and pure pigment stones are uncommon. Calcified gallstones vary in size and shape. Most gallstones have thin marginal calcification with central lucency and are laminated, faceted, or irregular in shape. Some gallstones contain gas in their fissures, whether calcified or non-calcified. Milk of calcium or limey bile occurs in patients with long-standing cystic duct obstruction. The bile contains a high concentration of calcium carbonate and is densely radiopaque on radiographs. You can see that in this image. Calcifications of the gallbladder wall, porcelain gallbladder, develops in patients with chronic cholecystitis, cholelithiasis, and cystic duct obstruction. So, porcelain gallbladder is characterized by curvilinear calcification in the muscular layer of the gallbladder, mimicking a calcified cyst. In general, ultrasonography is the primary modality now used to evaluate the gallbladder. So, those are the most important things I wanted to share about gallstones in this episode. Please visit our website www.drpaul.org. Thank you. May God richly bless you.